devices. I'll just try to brief upon various aspects of this vascular closure devices and troubleshooting in main, because that's the one which we all are worried about. So why do you want, when to use vascular closure devices? These are primarily used to achieve rapid hemostasis after the procedures requiring arterial access like cardiac catheterization, angiography, PCI or TAVA. Primary goal is faster hemostasis, reduce time to ambulation and discharge, and improved patient comfort compared to manual compression. Who are the ideal candidates? Patients undergoing any diagnostic or interventional procedures via common femoral artery, patients at risk of prolonged bleeding with manual compression, especially obese patients or on anticoagulants, or specific devices are available for use in large arteriotomy when you are using more than 8 or 9 French sheets using per-close or pre-close techniques. Contraindications, if at all, if you have done a puncture site below the bifurcation or above the inguinal ligament, then not to use this vascular closure devices. If there's a significant peripheral artery disease, severe calcification, the puncture site, or existing local infection, better to avoid or exercise caution. Morbid obesity or unusual anatomy where device cannot be properly deployed, extreme angulated tortuosities should be avoided as well. So which device to use? Broadly, they can be categorized into active closure devices as well as passive closure devices. Active closure devices are where the devices actively approximate the vessel wall or deploy a mechanical seal or a suture, providing immediate hemostasis. These are basically suture based. It can be a ProGlide or a Pro style. The mechanism is place a suture to mechanically close the arteriotomy. The pros are it's versatile for both small and large bore closures. Single or double techniques leaves a minimal foreign material intravascularly. Cons is it requires a good skill and anatomical knowledge. The other one is collagen based. So basically it deploys an anchor against the inside vessel wall and a collagen plug in the extravascular space. Very fast hemostasis, less operator dependent. Cons is it can leave a foreign material inside the vessel, so risk of distal embolization if the anchor dislodges. So re-access can be complicated if it had to be performed too soon in the same spot. So people say around 30 to 45 days you need to avoid accessing at the same spot. So clip-based are no longer available in India, so I'll not talk about it. The passive closures are the one which most of our cath labs have started using this as an access.
Constricts the wound along with the blood vessels and the surrounding tissue.
So what I'll do is I'll not go into the mechanism of those things. In summary, we have an intravascular as well as extravascular devices. So what we all know is suture-based devices and collagen-based devices are a patch or membrane-based. There are various devices available. The most common we all use is a ProGlide, Manta, and AngioSeal. So these things we should know in detail, like how to use. Of course, our own indigenous Merrill Subtura and Aptura Neo is also there. And even they have a ProGlide version as well. So again, this is the various animation videos. I'm sure these are available on internet and YouTube's. One can go through and refine your techniques of deploying it. I'll not go into detail of these things. So there's an AngioSeal. If somebody needs this presentation, it's already there in the deck. You can collect it as well. So various ways of deploying various things. We'll come to the major discussions. Why use VCDs? We all know the advantages. Faster hemostasis, earlier ambulation, reduced staff time because it frees up your clinical staff from prolonged manual compression, and lower complication rates. What is most important of this talk is troubleshooting and complication management. This is all we need to know. So if at all, when you're using a ProGlide and if there's a poor arterial flow or no flow, what does it mean? It means that the ProGlide is still not inside the vessel or the marker port is against the vessel wall. Do not deploy the ProGlide with the vessels less than 5 millimeter, or it could be because of the side walls stick. So gently rotate the device to move the marker port off the vessel wall, you might get it, or the patient might be having a significant hypotension. So slow drip might be acceptable in that case, but ensure that the BP goes up before you start actually deploying your suture. Or sometimes it could be a clot or tissue plugging the marker porter, because most of us don't give apparent before we actually get a big large bore access. So sometimes device itself is not in the lumen. So drip can occur when the marker port is near the vessel lumen, but not completely in the vessel. So continue advancing the pre-close or per-close until the brisk pulsatile flow is observed. And also the other important thing, you might see that already you have entered the skin, but the blood is not flowing because there might be a lot of obesity and major portion of your proglide might be in the subcutaneous tissue because of the Z tracking. This is one important thing which we all should look into. The other thing is a cuff miss. So when you withdraw, you see that there's no suture present in the plunger withdrawal. So tips of the needle did not lock with the cuff. Why is that? Either the tissue is too thick and the needles cannot lock the cuff, that is, there is a significant atherosclerosis in the vessel is diseased, or you're not advanced it enough, or probably you are at a very bad angle and you need to change the angle or rotate or clocking. So whatever it has happened, so the resolution is insert the wire, exchange for another device. You cannot use the same device again. So device failure and persistent bleeding. Somebody was asking about this. Apply immediate manual compression. If you had a stiff wire, obviously you can go to the other side, identify what is exactly happening and do. There was also a debate like, should we ask the vascular surgeon and closure, especially if there is a rupture or a major this thing. And what about the side branch loss? Whatever cases I've seen, both proctored as well as the institute, across the hospital, across the India. So whenever the vascular surgeon gets involved, the repair, even though whatever it is successful, 1 in 4 cases do have a prolonged stay, prolonged morbidities, limb is very much swollen, patient is in a pain. If at all, if your puncture is at least 1 centimeter above your bifurcation, don't worry about the profunda. You can go ahead and place your covered stent over the femoral puncture head, because the rupture is one thing which vascular surgeons also may not be able to localize at that site when the patient is actually in a hemodynamically bad shape. Occasionally, I've seen people closing off profunda artery also, and the patients are doing well because most of them are very elderly and their activity itself is limited. Having a profunda occluded and expecting the patient to develop a claudication is too long thing. So if they're already 80 years plus, I think sacrificing profunda is always okay in comparison to sending them for a vascular surgery and so on. The other dreaded complications of foot break, it has occurred to me a couple of times. So potential causes are either somebody has rotated or rocked the device excessively, or it is a shallow deployment. So the third thing is, what you can see is basically there's no suture or link, or sometimes only a link or no suture, or sometimes a missing foot plate. So this is what you can always see, and this is where we start potentially think about the foot break. So prevention is always ensure that the angle of deployment is not less than 45 degree. It should be at least between this 45 and 70 degree. Raise the device and maintain an even and gentle tension before even applying the suture. Press down in the plunger with a gentle increasing pressure to advance the needle, because if there is a small calcium speck, your needle can get deflected. And that might be one of the cause for these things. So device entrapment is another thing. Sometimes the foot plate gets in, but it is not coming out. So this can be because there is a separation of the proximal guide and the distal guide. So what you need to do is, or there could be malfunction of the liver foot wire control, and you'll be unable to close the foot due to tissue interference. So what generally we can do is, when the foot plate is not coming out, rather than trying to pull it out, try to use an ultrasound. Look at this. You can see that the foot plate is stuck here. We are trying to visualize this. And what we noticed here is the foot plate is behind this posterior wall calcific nodule. So what has happened is, at the puncture site, there was a plaque below. And without knowing that, or without looking for that, we only concentrate on the anterior location and we try to put the foot plate. And when the foot plate is coming back, it is catching the posterior plaque. And this is where it can come back and start suturing both the things together. And you can have an issue like an steno artery at the end. So ultrasound guide can save a complication. The other reason for device entrapment is you are unable to pull back the foot plate completely or remove the device. For this, what we did is we also tried some manual methods externally. So you can manually disengage the proximal and distal one, and you can try to open up with an artery forceps. Once you dislodge these things or dismantle these things, so what you can see is, you can see that the foot plate is stuck in an open plate here. What we are trying to see is if you can manually unlock and lock the device. You can see the foot plate is stuck in an open position here. What we are trying to do is hold both the ends together and try to push this and manually close this foot plate. So in this way, you can release the foot plate and then take out the entire device, and probably you can again take a new device and do that. Suture breaks. Suture may look thin and elongated. Rail or non-rail limbs can be broken. Prevention is keep the suture limbs coaxial to the suture trimmer and tissue. Do not pull laterally or medially on the suture. Always should be coaxial. Lack of hemostasis can be because of incorrect order of knot advancement. Sometimes locking the second suture instead of the first can happen, or it could be because of the tangled suture. So this is one of the reasons that we say that once you deploy a ProGlide, you should ensure that there's no suture slack inside the wound, and suture should be kept in a tight one and wetted, obviously. So current practices of mine is one suture-based VCT followed by collagen-based VCT, if at all, if needed. So if at all, if the major trauma, obviously retroperitoneal hemorrhage, other things has to be managed surgically or with a covered stent. One of the unusual cases, it was closed so badly, catching the posterior wall. There was a calcific block also. They had to use a rotablator, and this was published in 2025 in Journal of Invasive Cardiology. Infection is one more thing which we need to be mindful of, maintain sterile precautions as much as possible. So right now, my practice is, what I do is after my procedure, over the stiff wire, I will reinsert my microsheath. And with the ProGlide tightened over the microsheath, I take a micro injection over here. If the sheath is good, if there's no ILL perforation, anything, I just tighten this VCD or repass a wire, close this ProGlide, and then put an angioseal and then come out. So this has been my practice now. So I'll stop here. I've run out of the time. I will take another couple of minutes.
So, but you would still concede that a good closure begins with a good access.
Exactly.
So I think all of us need to be sensitized on the fact that evaluating the vessel, and you've very rightly pointed out, it is not only the anterior wall that you have to look for calcium, but also on the posterior wall. That is a very good representative case which you actually pointed out. So there are a few questions in everybody's minds with the surfeit of choices available today. In your practice, is it always a ProGlide or whatever its iteration and an angioseal, or do you think you waver from that and try some other devices like a Manta? Or when do you do it? When do you not?
Okay, so single access Manta, sometimes we do use it, especially when I use a newer valves like a Vienna or something which a bigger sheath. But if at all, if somebody has got a peripheral arterial disease or somebody is needing a multiple other interventions in the future, I try to stick to the suture-based devices, because in the suture-based, if at all, if there is some re-access is needed, I can always re-access even within few hours.
More control.
Sir, how do you decide the number of ProGlides you are going to use in that case beforehand?
That's a good question, sir. If at all, if my vessel size is more than 6 millimeter, and if my puncture is very neat and above, and when I take my first micro injection after putting the micro sheath, if things are very stable, there's no posterior calcification, I generally go with a one suture, one angioseal technique. If at all, if the vessel is slightly lower side, say less than 5.5 millimeter, I don't want collagen or anchor to be inside the vessel and cause a distal embolization on an already compromised vessel. In those cases, I preferably use two suture-based techniques, that is two ProGlide or ProStyle.
Any questions? Your point regarding the profunda is a very interesting point, because it has harassed me for a very long time. And then you go back to the basics and understand that critical limb ischemia requires 2.5 levels of occlusion. We keep teaching our students that profunda is like the left main of the lower limb. But at the same time, if your rest of the vessels are disease-free, and this is a life-saving or limb-saving measure, I would urge that you do save the life at that point in time, because it really saves a lot of vascular surgery morbidity which would happen. Any other questions?
Sir, suppose we are dealing with a patient who ultimately requires repuncture maybe in the future, maybe after 1 month or 2 month time. Then what should be our choice among this Manta or the ProGlide or the suture techniques?
So any collagen based, after 45 days of a user, you can re-access it.
Yeah.
I don't know how many of you have done a puncture in a collagen based vessel access at the same site. If he has done it, puncture is okay. Putting a 6 French sheath is okay. If you want to put a bigger sheath, there will be huge resistance. It will be like as if like you are going through a ligament. That you should be mindful of. So if at all, if you really need a bigger bore again, you need to dissect the soft tissues or a subcutaneous tissue and then track your device. I generally do a serial dilatation in those cases. Put a 6 French dilator, then a 7 French dilator, then take the bigger device, bigger sheath, whatever I want.
So in femoral and
Yes, sir.
And nowadays, there is some other things because when you are dealing with angioshield and it's failure and if you do, there is no wire, so it's almost over. So they are saying there's double wire technique. They put another wire there and then if it is failed, then you can do another wire, another angioshield.
So that only leaves some more small hole there and somebody has to manually come to the very purpose of VCD will be defeated. What I do is if at all, if you need that kind of a thing, that is where I have changed my practice. So after my ProGlide, so when I'm about to close my ProGlide, I put a micro sheet, take an injection over the ProGlide which is being tight. Now I know my 14 French hole has become a 4 French hole. So, and if there's no leak, I can just remove this and tighten that. If at all maximum, if there is a leak also, it's a 4 French hole. All you have to do is a manual compression of 4 to 10 minutes.
Srinivasa, any time you do one VCD with a manual compression is possible? One VCD with a manual compression. Earlier people were doing with...
So, yes sir, we also do an one VCD at most of the time. So, it's not like every case we do an angioseal or we follow with a collagen base. So, especially when we are using some of the self-expandable valves like a Navita, which requires only a 4.5 to 5 French axis, most of the times what we see is if the ProGlide is deployed well, that itself over a wire would have sealed off anything. Before locking the second suture, I remove the second wire also, lock it perfectly and there's no bleeding at all. So that happens in almost 20 to 25% of our cases.
sometimes in femoral angioplasty, when we use 7 French or 8 Frenches, there is hematoma around the sheath. In those cases, do you prefer manual compression or you need some vascular?
That's a good question. So that's a practical problem as well. So once you put a sheath and if the vessel is diseased, there is going to be a perisheath ooze. Or if you're using an aux catheter, obviously there's going to be a perisheath ooze. If you identify it early, you ask one of your Cath technicians, somebody to keep it holding so that there's no major hematoma collection. If already some hematoma has occurred, then generally what I prefer to do is I put a bigger nick, drain out all the hematoma.